My name is Dr. Krishna Rocha-Singh. I'm an interventional cardiologist and chief scientific officer at the Prairie Heart Institute in Springfield, Illinois, and I'm here to discuss the results of the REALITY trial. VIVA REALITY study attempted to explore a new treatment algorithm whereby directional atherectomy was used in a pairing with a drug-eluting balloon in an attempt to ascertain its safety and effectiveness. The rationale was specifically centered around complex lesion morphologies in the superficial femoral artery, and was quite distinct in its exploration of combining therapies of vessel preparation and antimitotic. The VIVA REALITY study included patients with significant and importantly complex occlusive femoropopliteal disease. It was unique in its inclusion in that it specifically required high grades of vessel wall calcification as assessed by fluoroscopy. This inclusion criteria was in part a challenge because not only did the patients need to have a certain grade of significant calcification, but they also had to have specific lesion lengths that had never been explored in this type of trial. So the exclusion criteria actually were, in a sense, a barrier to entry because it looked really at the complex of the complex. And I think that really was something that was distinct in the trial design. It's always been asked why this was a single arm trial as opposed to a randomized trial. The answer to that question, which is a good question, is that we were unaware of any appropriate control arm in dealing with patients that had never heretofore been evaluated in this type of trial. The only actual control arm would probably be surgery, which the task 2 guidelines in these type of patients felt was an appropriate therapy. So this single arm evaluation really looked at a very complex group of patients as defined by their inclusion criteria. The key results of a VIVA REALITY was that the patients with a significant amount of calcification as assessed by a novel calcium scoring system called the PAX index. This index required that bilateral calcification be present through a significant length of the vessel. The key results based on that important inclusion criteria was that number one, using a combination of directional atherectomy in concert with drug-eluting balloons resulted in a very low provisional stent rate, which was unique and an important finding. This provisional stent rate was 8.8%. Additionally, the freedom from clinically driven TLR at 12 months was exceptional at 92.7%, with a primary patency rate associated with that endpoint of 78.7%. So these three tenets, a very low provisional stent rate, an excellent freedom from TLR at 12 months, and a primary patency rate in concert with improvements in patients' Rutherford classifications and improvement in objective ABIs from baseline to 12 months really represents, I think, an exceptional data field that provides physicians with an important treatment strategy for this very complex patient population. I think the primary conclusions from Viva Reality are that patients that represent a far spectrum of complex femoropopliteal disease have available to them a clinically proven methodology to treat their disease, that being the fact that the combination of directional atherectomy and a drug-eluting balloon antimitotic is number one, safe, and number two, effective. The next steps after Viva Reality are to understand the following. Number one, um, this strategy pertains specifically to the use of directional atherectomy and the use of the impact admiral um, device. We cannot, unfortunately, generalize these findings to other combination of atherectomy devices or adjunct technologies to PTA with other drug-eluting balloons. The next steps, number one, therefore, is to extend this to other combinations of treatment strategies with vessel preparation prior to the use of an antimitotic. Number two, we have to validate outside of this trial the use of the PAX index. And this is important because there are several devices driven by single center retrospective studies that suggest this word of severe or heavy, however you want to describe calcification, now has a path forward to be validated so it can actually elevate clinical science in this very difficult patient population. In reading clinical data, it's important to understand several issues in placing this as potentially changing your practice style. Number one is the transparency of the data and the veracity of the data. Viva Reality was unique in that it had 4 independent core labs that evaluated its endpoints. Number one, it had a CEC, a clinical adjudication committee that evaluated all adverse events. It had an angiographic core lab. It had a duplex Doppler core lab. And one of the novel things, it had a histology core lab. In the manuscript that will follow, the readers will understand that all atheroma that was extracted from these patients was analyzed. And we now will have an assessment by a histology core lab to actually look at the elements that were extracted and specifically the amount of calcium and fibrocalcific disease that was removed by directional atherectomy. So I think it will add another layer of appreciation of the various modalities of vessel preparation and the importance of that as it relates to the 12-month clinical output.